Okay, good morning, everybody. Today I will make some short video lecture consulting you with some pictures on pathology. I'm not a pathology professor, as you know, but I see that you have some difficulties with understanding the pictures. It is not a lecture, it's a consultation. It means that you should be free to ask questions just now, because I'm here to help you. It's not a lecture. Okay, we will discuss first three topics on pathology. Very quick, very short. I will not explain you the theory because it was given you and you have the presentations. What you need is just to learn what is written on the slides. But if you don't understand something and you want me to explain, please feel free to ask the questions. I will pay more attention to histological pictures, histology and anatomy. So we start with the first topic, which was about the hemodynamic disorders. And if you want me to explain what we see on slides, please ask the questions, or we go next. We go here to the nutmeg liver. This is your histological preparation and your picture in your workbook, so you should understand what is it. Nutmeg liver, the word comes from the name of this nut, which on the section resembles the histological and anatomical preparation, because it has lighter and darker lines, which go from the center, darker and whiter lines. On the left you see the macro preparation, this is the anatomical cut of the liver, and on the right you see the micro preparation, the histological preparation of the same pathology. So this is the result, nutmeg liver is the result of the congestion in the liver. It means that the blood cannot return to the heart via the hepatic veins, because the heart cannot pump the blood properly and the blood stays in the veins before the heart, and it causes congestion. And it causes congestion in the liver. So in this slide you see normal liver on the left and nutmeg liver on the right. In normal liver, the surface is very smooth and no darker and lighter areas are seen as we see them in the nutmeg liver. So in normal liver it looks very equally stained. It is not the stained preparation, it's just the cut of the liver, anatomical preparation. Below you see normal and nutmeg liver on histological section. The same, in normal liver you cannot see any structures. All the tissue looks very equally stained. But in nutmeg liver you see these areas which have more red color. These are the areas of congestion. These areas are so red because of blood which stays in blood vessels, and these areas in histology correspond to the darker red areas in anatomy, and other areas correspond to more whitish areas in anatomy. In normal liver, what we see that it is composed of so-called lobules. This hexagonal structure, hexa means six angles, it is called hepatic lobule. All the liver is composed of such lobules. Every lobule has a central vein in the center. This is what we see if we make the section like this. We see this surface. In the center, we see the central vein. This dotted line shows the border of the one hepatic lobule. It is not so correctly hexagonal as it is in this diagram, but the general idea is the same. In the center, we have the vein, and at the borders of every hepatic lobule, and so it means that between the adjacent lobules, we have three vessels, which is shown here: a vein, an artery, and a bile duct. They are three, and this is why they together are called triad. It is called portal triad. It is located at the border between the two adjacent lobules. The blood in liver normally flows from the triad, where we have the artery, through the lobule to the center, and is drained from the central vein. And it happens from all the sides of the lobule. You see that the lobule is composed of the cells, which are called hepatocytes. They are arranged in these trabeculae, and between the trabeculae there are sinusoidal capillaries. You know sinusoidal capillaries from histology right now, so this term you also should know. So if we look at the hepatic lobule, we see that from the periphery to the center run the trabeculae of hepatocytes and the sinusoidal capillaries which separate them. The same is seen in histological preparation. You see more darker red lines and more lighter areas. More darker red areas are corresponding to hepatocytes, and between them lighter spaces are sinusoidal capillaries. So this is the direction of blood flow normally in liver. Blood flows from the periphery, where the artery is located, from the triad to the center. The same at higher magnification. We see central vein in the center, portal triad. Triad, the word means three elements. So it contains of 1, 2, 3 elements. One of them is artery. So the blood comes from artery to sinusoidal capillaries and flows to the center. The sinusoidal capillaries are those lighter spaces between hepatocytes. Hepatocytes are eosinophilic in color. You see their nuclei here. Now, what happens during nutmeg liver pathology? Congestion in the center of hepatic lobules causes the dilation of central vein. In this picture, it shows one trabecula of hepatocytes. These cells are hepatocytes, here and here. Between them, there is a sinusoidal capillary. Through the sinusoidal capillary, the blood flows from the portal area, which should be here, to the central vein, which should be here in this picture. So the first picture shows what is normally happening in the liver, and then congestion happens. So there we see the increase in the amount of blood, red blood cells. Why? Because they cannot go further from the liver towards the heart. Heart doesn't receive blood because it is too weak. So blood stays here, it cannot go to the heart, and it causes congestion and dilation of the central vein. Dilation means increase in diameter. Next, centrally located hepatocytes undergo necrosis. Centrally located means those which are closely located to the central veins. It means these. These are central hepatocytes, and those at the opposite side will be called um, periportal. Periportal means more closely located to the portal triad, which contains artery, which is on this side. So centrally located hepatocytes undergo necrosis. It means that they start to die. These. Next, periportal hepatocytes, which experience less severe hypoxia, may develop hypertrophy and then fatty change. Here you see O2 goes down. It means that all hepatocytes start to experience hypoxia, which means they do not receive um, sufficient amount of oxygen because blood doesn't go anywhere. It just stays here. The blood should go from the artery through the sinusoidal capillary towards the central vein and then out from the liver. But congestion means that blood stays here and doesn't move. It means that no new portions of blood rich in oxygen come to this area, and it means that finally all our hepatocytes will receive decreased amount of oxygen. Oxygen level goes down. Um, and those hepatocytes which are located more closely to the artery, which should be here, they receive more oxygen than those located closely to the vein, to the central vein. It means that uh, these centrally located hepatocytes will experience more severe hypoxia and start to die. Those which are periportal hepatocytes, they develop hypertrophy. Hypertrophy means increase in size, and then fatty change. You see it in the next picture. These yellow drops in the cytoplasm of the periportal hepatocytes, they mean the fatty degeneration, which means that there is the accumulation of lipid droplets inside the cytoplasm of the cell because um, because of the failure of mitochondria. Mitochondria, as you know, they produce ATP from the oxygenate uh, as a result of the um, oxygen which should oxygenize the fats and other organic molecules. So mitochondria needs fat and oxygen. Oxygen is combined to fat, and this chemical reaction causes production of ATP molecules. This is how mitochondria work. It means that they need both organic molecules, such as fats, and oxygen to uh, oxygenize organic molecules and produce ATP. Here we see the lack of oxygen. It means that oxygen cannot oxygenize um, lipids, and lipids are not converted to ATP. They just stay accumulating inside the cytoplasm, and it is called fatty degeneration, fatty change. It happens in the most peripheral cells, periportal cells. What happened to the centrally located hepatocytes? They underwent necrosis, the cell death. So here you see dead cells. Proliferation of connective tissue in the center of the hepatic globules, periveneal fibrosis, then in the sinusoidal capillaries and in the portal tract. In the third picture, green color marks the connective tissue. Green color is for connective tissue. This connective tissue is produced by specific Ito cells, like this one. So um, is, the production of connective tissue goes along the sinusoidal capillary, and finally at the area of the portal triad. In this area we will have the fibrosis. Fibrosis means that here we have increased amount of connecting tissue. Sorry, back here. Next, blocked interaction between capillary and parenchyma. What does it mean? That all the cells, hepatocytes, receive oxygen and nutrients from blood through this space between the endothelium of sinusoidal capillary and the membrane of the hepatocyte. So these oxygen and nutrients should come this way from blood to hepatocytes. But now we have the connective tissue between blood and hepatocytes. It means that the passage of nutrients and oxygen is now blocked. And finally, what we have, nutmeg liver fibrosis. Fibrosis means overgrowth of connective tissue, and cirrhosis, which means combined overgrowth of connective tissue and death of parenchyma. Parenchyma means the main tissue which performs the main function of the organ. In the case of liver, parenchyma is hepatocytes. So finally we have dead hepatocytes and overgrown connective tissue, mostly at the periphery where we have the portal triad. So what we have in the center of the lobule of the liver, we have the central vein, which is dilated and congested. Dilated means that its diameter is increased, and congested means that there the red blood cells are stuck. They just stay here and do not flow anywhere. Next, we have the area of the central hemorrhagic necrosis. This area corresponds to the area where hepatocytes are dead, here. Central means closer to the central vein and to the center of the lobule. Hemorrhagic means hemorrhagic necrosis means death of cells and bleeding of capillaries. So erythrocytes go to the spaces between the dead cells. This is what we see in this zone. Next, we see the area of the hepatocytes which are located more peripherally, more closely to the area of portal triads with arteria. This area corresponds to these cells. Here we see the fatty change, fatty degeneration of hepatocytes, which means accumulation of lipid droplets inside their cytoplasm, because lipid is not converted into ATP because of failure of mitochondria, because of lack of oxygen. And here around the portal triad areas, we will also have the fibrosis, overgrowth of connective tissue. So what we see in histological specimens is, this is the picture from the presentation. Number 1 shows sinusoidal dilation. Sinusoids here are the non-stained areas between hepatocytes. Hepatocytes are eosinophilic, they are here. So the areas between them are sinusoidal capillaries. They are dilated, it means that they have a very wide diameter. Number 2 shows periportal hepatocytes. So this area corresponds to this one with the fatty change. It is the area of periportal hepatocytes which are located at the periphery of the lobule, more closely to the portal triad. Portal triad number 4. It contains 3 elements. 1 2, 3. One of them is artery, and the blood in the lobule goes from the periportal area through the sinusoidal capillaries to the central vein. And portal areas are unaffected now. Another picture showing nutmeg liver. Here, number 1 shows centrilobular hepatic necrosis. This area, central hemorrhagic necrosis, it shows dying cells. Dying cells. Here you see normal hepatocytes. They have pink cytoplasm and nuclei very well seen. In this area you see no cell borders and no nuclei of the cells. Only some nuclei still are present. Most of the nuclei in this area are the nuclei of sinusoidal capillary endothelium. So here hepatocytes are dying. Centrilobular hepatic necrosis, which means necrosis of hepatocytes which are located closely to the central vein here. And number 2 is for dilation of sinusoidal capillaries. This whitish space is the sinusoidal capillary. So hepatocytes here, and between them sinusoidal capillary, more whitish space. This is the capillary through which blood flows in this direction to the central vein. So in the case of nutmeg liver, the width of sinusoidal capillaries, their diameter is enlarged. It means sinusoidal dilation. So once again, normal liver, very small diameter of central vein compared to the diameter of central vein in nutmeg liver. Then normal hepatocytes around central vein in normal liver, and necrotic hepatocytes around the central vein in the nutmeg liver. Then here is the area of the portal triad. It should be here in this area in this picture. And in normal liver we cannot see clearly the borders of the hepatic lobule. It is very hard for us to see it because between the lobules, at the border of each lobule, there is some amount of connective tissue. Normally we have very few amount of connective tissue, but in the case of nutmeg liver we will have the fibrosis in the area of portal triad at the periphery of the lobule. It means the overgrowth of connective tissue, which is more light in color in this particular picture, and it means that we can see the periphery of the lobule very clearly because of enlarged amount of connective tissue. So the areas in this picture are central vein in the center, then the area of central hemorrhagic necrosis is here, then the area of fatty change of the periportal hepatocytes at the periphery of the lobule, and finally the area of the portal triad filled with overgrown connective tissue. Okay, this is all about the nutmeg liver. If you have any questions, please feel free to ask them, because I'm here to explain you anything that you like. If there are no questions, we will go to the next preparation, which is the preparation of brown induration of the lung. On the left you see the anatomical picture of the normal lung. This is how it looks like. It should be pink, light pink in color, and its tissue is very soft. It is very airy because it contains of alveoli filled with air, so it is very light and pink. What means brown in duration? Brown means change of color. You see that color here is brown. In duration means hardening. Dura is the Latin word meaning hard. So brown in duration literally means that the lung becomes brown and hard. Normal lung should be pink and soft. On the section, the same. Normal lung should be pink. Red is because of a lot of blood capillaries which fill normal lung. And on the section, brown in duration of lung looks like this. You see brown tissue, and it is brown and hard. So normal lung contains multiple alveoli, which are these areas, sacs, which wall is made up with flattened cells, which are called alveolar sites or pneumocytes. So they are very thin, and every alveolus is surrounded with tiny blood capillaries. You see here sections of blood capillaries which serve for gas diffusion, gas change between the blood in these capillaries and the air inside the alveoli. So the function of lungs to bring oxygen to capillaries. It means that oxygen goes from air to blood capillaries, and from blood capillaries through the wall of alveoli, CO2 gas goes to the air inside the alveoli. So here you see the gas exchange between the air in the alveolus and the blood in blood capillaries through the very thin wall. This is how normal lung looks like in histological preparation. These um, not stained areas are inner spaces of alveoli. They are not filled with anything because they should be filled with air. Air goes in alveoli, and these are the walls of alveoli. They are made up with very thin alveolar sites, one alveolar site layer which corresponds to this alveolus, and second layer of flattened alveolar sites which correspond to this alveolus. You see it in this diagram, one alveolar site here, one alveolar site here, and in the very tiny area between them there are blood capillaries. Blood capillaries can be seen here because you see erythrocytes inside them. After all, the thickness of these walls between the adjacent alveoli should always be very, very thin, because only thin walls can um, provide gas exchange. Now, what happens during brown induration of the lung? Congestion in the pulmonary circulation and adaptive changes in the lung blood vessels, hypertrophy of smooth muscle cells. Congestion in the pulmonary circulation. You see here the pulmonary circulation. Um, the left, no, the right ventricle sends venous blood, pour in oxygen to the lungs. There, in capillaries, there is gas exchange and oxygen goes to the blood, and what we see then, the blood is returned to the heart. Congestion in pulmonary circulation is caused by the weak left portion of the heart. It means it cannot receive blood rich in oxygen from the lungs. So the blood stays in lungs. It causes congestion. Then multiple diapedetic hemorrhages from vessels of intraalveolar septa. What does it mean? Multiple diapedetic hemorrhages. Hemorrhage means bleeding. Diapedetic means hemorrhage per diapedesem, bleeding due to a defect in the permeability of the vascular wall. It means that there are some gaps and holes between endothelial sites, which are normally not present. Normally we have no gaps, no holes between endothelial sites of blood capillaries, which are between the alveoli, in the wall between two alveoli. But now, because of congestion, because of increased blood pressure in these capillaries, there we will have some newly appearing holes and gaps between the blood, between endothelial sites, and blood starts to go out from the capillary. First, it goes just in this tiny area between the alveolar sites in the uh, wall between the alveoli, but then this increasing amount of blood in the wall between the alveoli, this blood starts to go into the alveolar space, which should be free of any tissue, of any cells, and only gas, only air should fill the inner space of alveoli. But now um, the hemorrhage, bleeding happens, and blood starts to go to the inner space of alveoli. Then destruction of erythrocytes and hemoglobin happens in the alveolar space. It means that erythrocytes that came into alveoli are dying, degenerating, are broken, and hemoglobin is released from these erythrocytes. What happens next? Diffuse pulmonary hemisiderosis. It means that the hemoglobin is eaten with macrophages, which are normally present in the alveoli. And what also happens, diffuse pulmonary hemisiderosis, formation of numerous macrophages laden with hemisiderin. These macrophages are called heart failure cells. Blocked interaction between capillary and parenchyma, and diffuse pneumosclerosis and chronic pulmonary heart disease. What does it mean? Here you see what happened to alveoli. Inside the space of alveoli, now we see these large cells filled with brown granules. These are macrophages that have eaten erythrocytes, which came from blood capillaries in the wall of alveoli to the alveolar space. And these macrophages are called heart failure cells, because their presence is the mark of heart failure. As you know, the heart failure causes congestion in pulmonary circulation, which causes brown induration of lung. So this disorder is caused by failure of the left part of the heart. So here in this picture you see the histological preparation. This is the wall of alveolus, alveolar wall. This is the space of one alveolus here, space of another alveolus here, space of another alveolus here, etc. You remember that normally there should be nothing inside the alveolus. But here you see some cells, some fluid, something between the cells. and these large cells with brown granules. Brown is the color of degenerating hemoglobin from blood capillaries. So, what we see in brown induration of lung, the alveoli now are filled with um, fluids and cells and erythrocytes and these heart failure cells. And as you understand, such alveolus, which is now filled with a lot of things, cannot perform the function of breathing, cannot perform the function of gas exchange, because air cannot go here. So this alveolus cannot work. Uh, what else happens? The thickening of the wall of the alveolar septa. Septa means the wall between two adjacent alveoli. You remember that normally it should be very, very thin, but now it becomes thick because of overgrowth of connective tissue around blood capillaries in this wall. And overgrowth of connective tissue is called sclerosis. So we have now pneumosclerosis. Pneuma means lungs. Sclerosis means overgrowth of connective tissue, mainly in the walls between alveoli. But also you see some cells in the alveolar space. It means that here the cells of loose fibrous connective tissue also go, and they also can make connective tissue here. Blocked interaction between capillary and parenchyma. It means that there cannot be any gas exchange now. Heart failure cells are those macrophages filled with hemosiderin, the result of breaking down of hemoglobin. Pearl's stain is the type of staining which help us to see iron element, iron molecules in the structure of hemosiderin. So here you see brown induration of lung, anatomical preparation. Here you see that lung is brown and hard, and histological preparation. Some alveoli look rather normally, they are not filled with anything inside, and the walls are very thin in some areas, like here and here, but in other areas the walls are thicker, and here also it is not normal. And in these areas you see that the inner space of alveolus is filled with heart failure cells. There should be nothing inside the alveoli normally. So normal lung on the left and brown induration of the lung on the right. Thin alveolar walls normally become thicker in the brown induration, and nothing inside alveolus. Normally in brown induration, inside alveoli we can have some fluid cells and heart failure cells, brown in color. So the same on high magnification. All this is the alveolar space, because here where you see pink color, this is the wall of the alveolus. This is the wall. So everything inside is the alveolus space. It should be free of anything normally, but now we see here a lot of cells and some fluids. And number 2 for heart failure cells with brown granules of hemosiderin. Number 3, edema fluid. So all the space here between the cells is filled with the fluid. This fluid is actually the blood plasma, which during the hemorrhage came from the blood capillaries, which are in the wall, to the inner space of the alveolus. In this picture, we see the Pearl's stain. Pearl's stain stains hemosiderin and basically iron in the structure of hemosiderin in blue color. So these are heart failure cells. They are blue because the iron in hemosiderin is stained in blue color with Pearl's staining. They are located inside the alveolus. Here should be nothing, but now we see here these cells. Number 2 is for alveolar septa. Septa is this wall between two alveoli. One alveolus here, second alveolus here. The wall between them should be very, very thin, but now it is very thick. And some heart failure cells are present also inside this septa. Number 3 is for congestion of blood vessel. Here is the wall of the blood vessel. We cannot say which blood vessel is this, but it should be the vein. Congestion is when blood stays in veins and cannot go further towards the heart because of heart failure. So if we are talking about congestion, this blood vessel should be the vein. It is overfilled with red blood cells. So here we have the congestion of blood vessel. If you have any questions, please ask them now. Or we go next. Some of you asked about this slide. You should just learn the information which is shown here about hemorrhage, which means bleeding, external examples of bleeding, where blood can come from nose, during vomiting from stomach and intestine, during coughing from lungs and bronchi, um, from intestine with the stool, etc. So external bleeding when the blood comes from inside of our body outside. Internal bleeding means that blood doesn't go outside from our body and stays somewhere inside the body, mainly in the cavities. So blood in pericardial cavity, hemipericardium. When some injury happens to the heart, the blood can stay in the pericardial cavity. Hemothorax, blood in pleural cavity. When something happens to lungs, blood will stay in the pleural cavity, etc. Hemorrhagic mechanisms is how blood can go from the blood capillaries, include perrexin, bleeding during rupture of blood vessel, during trauma, aneurysm, etc. So here you see normal endothelial cells. They are ruptured for some reason, for example, because of maybe very high pressure. So we have the rupture and the blood goes outside. Next, diapedicin means that here we have increased permeability of the endothelial cells. It means that it's okay with endothelial cells, they are not ruptured, they are alive and everything is okay, except holes and gaps between them. So here we have increased permeability, and through these gaps and holes, blood can go out from blood capillary. And finally, hemorrhage per diabrosin means the erosion of vessel by some pathological process, such as tumor or ulcer. So here you see dead endothelial cells. They were killed, for example, by maybe gastric juice. If we are talking about the stomach ulcer, which means when the acid which fills normally the cavity of the stomach, for some reasons disrupt the wall of the stomach and goes deeply to the wall of the stomach, where it also uh, forms erosion of blood vessels. It means that here endothelial cells are dead because of acid from the stomach. So it can be the cause of such hemorrhage per diapedecin. So here we have the hole and blood goes out. In this picture we see the hemorrhage per rexin. You see here the lower surface of the brain, and you see here massive hemorrhage, massive bleeding. It is subarachnoid. It means that blood is between pia mater and pia arachnoid. Some blood vessel is ruptured. Blood vessels are located in the pia mater and they come there from pia arachnoid. So rather large blood vessels are located just between pia mater and pia arachnoid. You see some blood vessels here. And somewhere we had the rupture of such blood vessel, and the blood came in the subarachnoid space between pia mater and pia arachnoid. So we see here a lot of blood. Here we see hemorrhage per diaprosin. This is just the thing that I was talking about a minute before. Upper digestive endoscopy, ulcer of the gastrojejunal anastomosis. So here is the wall of the stomach. When we look from inside, the camera is placed inside the cavity of the stomach, and we see the surface of the stomach. For some reasons, something bad happened to the mucosa, the inner surface of the stomach, and the acid from stomach came deeper into the wall of stomach, and there it caused um, erosion of blood vessels, and blood goes from blood vessels, and it can be seen now from the surface of the stomach. In this histological preparation we see hemorrhage per diapedecin. Number 1 shows bleeding per diapedecin into brain tissue. Number 2 is for congestion of blood vessel. So this is the blood vessel, a vein or a venule. Because we are talking about congestion, congestion is always about veins. So here is some vein or venule with very thin wall of endothelial cells. It is overfilled with blood, so here we have congestion. And because of increased pressure inside the venules, which cannot resist high pressure normally, there some gaps and holes emerge between endothelial cells, and blood start to go out from the blood capillary to surrounding tissues. So here we have these blood capillaries. So actually this area, lighter stained, between the erythrocytes inside blood capillary and erythrocytes number 1 here, this area is actually the wall of the vein or a venule. So we see here not damaged endothelium, not damaged, not ruptured wall of this blood vessel, but for some reason erythrocytes came out from blood vessel to surrounding tissues. It means that here we have the hemorrhage per diapedecin, not because of rupture of the wall, but because of emerging of the gaps and holes between the endothelial cells which are still alive and okay. but because of increased blood pressure, we have these holes and gaps now. So blood cells came out and can be found now around this blood vessel. Here in this picture you see anatomical preparation and the view of legs and arms. Uh, these pictures show different types of hemorrhages, such as hematoma, hemorrhagic infiltration, petechiae, purpura, and ecchymosis. So this picture shows intracerebral hematoma, which is here. Damaged tissue is very well seen. It is the cavity filled with blood and distracted tissue. Brown color is because of uh, hemosiderin and dead tissue here. Next, petechiae. Petechiae are dot-like bleedings. This is the colonic mucosa. It means that we took a colon, we cut it along, and now we see the inner surface of the colon. So we see mucosa of the colon, and we see these dot-like bleedings, 1 to 2 millimeter in diameter. Next, purpura are dot-like bleedings, but they are larger, and ecchymoses are subcutaneous hematomas which are much larger, several centimeters in the diameter. So what we see is the blood which came from blood capillaries, and it is seen now from above. The color of ecchymosis will change from red, then to blue, then to green, and then to yellow because of transformation of hemoglobin into hemosiderin and other forms until it is um, taken away from here with the help of macrophages, which will come to this area and eat the dead erythrocytes. In this picture, we have the hemorrhagic infiltration into brain. Normal brain tissue is shown on the left and the pathologic on the right. So what we see here, number 1 is for hemorrhagic infiltration. It is red because of red blood cells. Number 2 is for pericellular edema. Number 3 is for perivascular edema. Uh, this picture shows the same on high magnification. Edema means the accumulation of fluid around something. Pericellular means around cells. Perivascular means around blood vessels. So as you see here, we have here some cells and white space around them. This white space actually is filled with fluid, which we will call pericellular edema. Pericellular edema, fluid around the cells. Here you see blood vessels, blood capillaries, and around them also white spaces. They are perivascular edema. So in this picture, number 2, pericellular edema, they are whitish areas. They are very small. We have here low magnification, so we cannot see cells actually. But these whitish small areas correspond to the areas around the cells filled with fluid. Number 3, here you see blood vessel, and the white area around it is actually the area where fluid stays, and this is perivascular edema. It looks like this in this picture on high magnification. So it is all about the hemodynamic disorders, please ask your questions if you have them. If not, we go next to your second topic, which was about the thrombosis and embolism and disseminated intravascular coagulation. This picture shows the thrombus and post-mortem clot inside some blood vessel, which is cut along its long axis. So here you see internal space of the blood vessel. This is its wall. And here also it was cut longitudinally, and we see in its space, internal space, here a thrombus, and in the second picture, the post-mortem clot. So this is a description of the difference between the thrombus and post-mortem clot. So it is dry and firm and friable. It means that you can detach some pieces of it very easily. In post-mortem clot, it is gelatinous, jelly-like, and soft and rubbery, like rubber. The platelets are absent in the post-mortem clot, but they are present in the thrombus. Thrombus is attached to endothelium. You cannot detach it very easily, unlike post-mortem clot, which is not attached to endothelium. And lines of Zahn are present in the thrombus and absent in the post-mortem clot. Lines of Zahn are seen only in histological sections, not in these pictures, not in anatomical ones. This picture shows the difference between red and gray-white thrombus. The major difference is in the color. Red looks more red, gray-white makes paler. Why so? Because red thrombus contains more red blood cells, and gray-white contains more white blood cells. Red one contains also white blood cells, but it contains more of red blood cells. This gives the color. Red color here comes from large amount of red blood cells. In both cases, we have the fibrin. Fibrin is the non-soluble form of the protein of the blood plasma. In histological sections, fibrin is eosinophilic. It means that it is stained in pink color. So these more pinkish looking areas are the areas filled with fibrin, and everything which is pink in the picture on the right is also fibrin. So in the picture on the right, in great white thrombus, pink color is for fibrin. White blood cells are seen by their nuclei. So these are cell nuclei of white blood cells, leukocytes. In red thrombus, we see more red color for red blood cells. Here they are, and here also. More pink color for fibrin, and also some white blood cells are seen here because of their nuclei. In this picture you see the cross-section of blood vessel, which wall is marked with number 2 here, and its lumen is almost close with the thrombus, number 1. All this structure is the thrombus. Number 1 shows lines of Zahn, which are pale and red areas. Pale areas correspond to platelets and fibrin, and red areas correspond to red blood cells and fibrin. So this zebra-like appearance is the presence of lines of Zahn. Here we see organization of a thrombus. It is one of possible outcomes of thrombosis. Organization means the growth of connective tissue into the thrombus. What we see here, number one is for the wall of this blood vessel. So this is the wall of blood vessel here. It has the space here, non-stained, and inside it we have the thrombus. The thrombus is attached to the wall. It is the feature of thrombus, unlike postmortem clot, which is not attached to the wall of the blood vessel. The thrombus is attached. So here you see the area where the blood vessel tissue is attached to the tissue of the thrombus. In this thrombus, number two is for it. All of this actually is a thrombus. But in some areas, number three area, we see connective tissue which came from the wall of blood vessel in this area to grow into the thrombus. So in the area number three, connective tissue, which is more pale looking, had grown into the thrombus. As we see here, it will continue to grow this way. And this is what is called organization, which means that fibroblasts, which came from the vessel of the from the wall of the blood vessel, infiltrate the thrombus and lay down collagen fibers to form connective tissue scar. This is what we see here in number three, connective tissue scar. It contains cell nuclei of fibroblasts and fibrocytes and other cells of connective tissue and collagen fibers. Number four shows the process called revasculation and vascularization and recanalization. It means that new blood new blood vessels appear inside the thrombus. The endothelial cells which cover the internal surface of this large blood vessel start to proliferate and form new blood vessels which grow into the thrombus and make new blood vessels inside the thrombus, and through these new blood vessels blood can flow through this large blood vessel. So initially this thrombus has plugged almost all the internal space of this large blood vessel, but now we have additional uh, small vessels inside the thrombus, and through these blood vessels blood can still pass through these large blood vessel. So new blood vessels, revascularization, recanalization are good outcome of the thrombosis. They allow blood still to flow through these large blood vessels, through the area filled with the thrombus. Almost the same picture at high magnification, organization of a mixed thrombus. Number one is for the vascular wall. This is the vascular wall. So here should be the endothelium of the blood vessel. Here is it. Number two shows the inflammatory reaction with fibroblast infiltration, and number three is for thrombus. As you know, thrombus is connected to the wall of blood vessel, so we see here no space between the wall of blood vessel and the thrombus, because thrombus is connected to the blood vessel wall. And number two shows us how the fibroblasts and granulocytes come from the blood vessel wall to the thrombus. Inflammatory reaction means the presence of neutrophils, macrophages, and other leukocytes which function is to perform inflammatory reactions. They are the cells of loose connective tissue, as you know, because they perform their functions not in blood but in connective tissue. So they came this way to perform their functions, inflammatory reactions, and fibroblasts, which came with them also. They will make organization, the growth of connective tissue inside a thrombus. So here fibroblasts, they start to make collagen fibers. Next, embolism. Um, Here we see the tumor tissue embolism. Number one shows us the tissue embolus. It's a piece of tumor tissue. Uh, Here we see the metastasis in the process of cancer. Metastasis of cancer. Pieces of tumor tissue travel along our body within blood vessels to go to other organs. So this is the blood vessel. Inside it we have some piece of tissue which is the embolus. Embolus is anything present within blood vessel which normally should not be there. So no tissue should be inside blood vessels except blood. No gases, no lipids. So embolism means the presence inside the blood vessels of those things that should not normally be there. In this picture, we see the example of embolism, the tumor fragment tissue embolism, the presence of pieces of tumor tissue inside the blood vessel. Actually, we see here the um, portion, part of the section of the lung. So number two shows the lung parenchyma. Um, Here we see the alveoli at very low magnification, so it is hard for us to see them. Number three shows us the large bronchus. So number two and number three, um, you should not remember them because it describes the structure of the lung. It is not your topic here. Your topic here is about this, about blood vessel and the piece of tumor tissue within it. So it happens in lung, so possibly we have here the metastasis in lungs. The same at high magnification. Number two shows us the wall of the blood vessel. Number one shows tissue embolus in the lumen. You see here no attachment here of the tumor to the blood vessel wall. Number three shows us the parenchyma of lung. Still rather normally looking because the alveoli are not filled with any tissue, they are filled with air, and the walls between them are rather thin. But your topic is not about the lung, it's about this part, number one and two. Next, bacterial or septic embolism shows us the picture showing the section of the kidney. Number one shows bacteria embolus. So this bluish looking piece is the collection of bacteria. They are located in some very small blood vessel, which is not very well seen here. Number two shows us the glomerulus. Glomerulus is the area where the blood filtration happens in kidneys to make the primary urine. So it happens here in glomerulus, one glomerulus here, and second glomerulus here. Number three is for leukocyte infiltration of the renal parenchyma. Here you see a lot of cell nuclei located very close together. It is not normal for the kidney. It means that we have here additional cells. In kidney, we should normally have the cells which make nephrons of kidneys. But here we have lots and lots of cells. It means that here we have incoming cells. They are cells, leukocytes, which came here to fight infections. Because here we see bacteria, so the bacteria will not be only inside blood vessels, they will finally go outside, and it causes the leukocytes to come here in this area to try to fight the infection. Next, here we have fat embolism on the left and amniotic fluid tissue embolism on the right. So what we see here is the blood vessel wall, which is not very well seen. It should be here, blood vessel wall. And we see the fat droplets, fat drops within its lumen. No fat drops should normally be inside blood vessels, but here we see them. And picture B shows the other staining, not hematoxylin eosin like in A, but in B we have Sudan 3 staining, which stains lipid in red or orange color. So the same, which looks like pale, I'm sorry, filled with nothing area, white. This area corresponds to this stained in orange color. So these are fat drops stained in orange color with Sudan 3. Here we have the amniotic fluid embolism. It happens during pregnancy in women. Amniotic fluid surrounds the developing baby inside the mother's womb. So, for some reasons, this amniotic fluid can come into the blood vessels of the mother, and there it causes amniotic fluid embolism. So number 1 shows us laminated swirls of fetal squamous cells. So these are the cells of the baby, of the fetus, inside the blood vessel. Here is the blood vessel wall. Number 2 shows us the small pulmonary arteriole. It means that we are in heart. So it is the pulmonary arteriole, and inside its lumen we have these laminated, which means many layers, swirls, which are surrounding each other, of fetal squamous cells. And number 3 shows us edematous and congested lung parenchyma. So once again we are in lungs. Congestion means the enlarged amount of red blood cells in blood capillaries. And finally, blood stasis means the stopping of flow of blood in the blood vessels. So picture A is low magnification, picture B is the same on high magnification. We see here blood capillary in the brain tissue. It is the blood capillary because the inner space can contain only one erythrocyte in the width of diameter. So it's the capillary endothelial cell nucleus, another endothelial cell nucleus, and the erythrocytes are very closely staying together. They are in the form of the stack of coins. Form of coins, stack of coins. This is the feature of blood stasis. So congestion, for example, can cause the stasis if there is no outflow of blood from veins towards the heart, it means that there should be also no outflow of capillaries towards the veins. It means that blood stays in blood vessels. And finally, your last topic about necrosis and apoptosis. I think that there is almost nothing to explain here. So, this picture shows a necrosis of the splenic follicle. We are in spleen, the organ which performs the function of blood filtration and immunity. Follicle means the major structural unit of the spleen. All this round structure is a follicle. You shouldn't know now these terms, but the spleen and follicles, you should just be able to distinguish between the cells which are alive and the cells which undergo necrosis, which is the massive cell death. So, in this area, you see normal alive cells, the cells which surround our splenic follicle. But inside the follicle, in the area where we have 1, 2, and 3 arrows, here we have necrosis. So all this is the necrotic area. Number 2 is for karyopyknosis, and number 3 is for karyolysis. These are the sequentive features of the changing of the nuclei of dying cells. So during the death of cells, their nuclei undergo first pyknosis, which means the squeezing of the nucleus. It means that the nucleus becomes smaller and darker. Next, we will have karyorrhexis, which means that this pyknotic nucleus is broken into smaller pieces. And finally, we will have karyolysis, which means the digestion of these pieces of broken nucleus with the enzymes of lysosomes of the cell. So we will see these karyopyknosis and karyolysis events only if we make the high magnification, because we should look closer to cell nuclei. These processes describe what happens to cell nuclei. Karyon is Greek for nucleus. So the same picture on the high magnification showing our follicle here. So necrotic area is all this follicle here. And what we see here, first, karyopyknosis is when cell nuclei become smaller and darker looking. To find such nuclei, you should first find normal nuclei. Where we have normal nuclei? Around our follicle. In this area, for example, here and here, they should be lighter and larger normally. So this one, dark and small, is the karyopyknotic nucleus, smaller and darker. Then goes karyorrhexis, is the area where you have just very small dots in the area where cell nuclei were present. So these, the tiniest blue dots, correspond to the pieces of the nuclei of dead cells. Very small dots. This is karyorrhexis. And finally, karyolysis is the area where you do not see any cell nuclei now, because all of them disappeared as a result of karyolysis. So here you see the digesting pieces of the nuclei. Nuclei disappear. Next, types of necrosis, coagulative necrosis. In this picture, you see the coagulative necrosis in the kidney. This white triangular in shape area, it's the area of necrosis, which is caused by um, stopping of blood inflow to this piece of tissue. This picture shows the blood supply of the kidney. The blood comes here through the arteries, which then split into smaller arterioles, etc., and give blood supply to this area. It means that this arteria will give blood supply to all this area. If something happened to this arteria, for example, thromboembolism closed this arteria in this area, it means that no blood will flow further to these smaller arterioles, and all this area of tissue will undergo necrosis because of lack of oxygen and nutrients. And this area will be triangular in shape, and this is what we actually see in this anatomical preparation. So something happened in this area here to the arteria, some artery, and no blood came in this area. This is what we see on histological preparation of the kidney. Number one shows us the normal tissue. Here you see the cells of nephrons of kidney. We see the borders of the cells, their cytoplasm is eosinophilic, and the major feature, we see cell nuclei. It's the major feature of the cells which are alive, the presence of normal cell nuclei. In number two, we still see the shape, normal shape of nephrons, nephron tubules cut in different planes of sectioning, and we see eosinophilic cytoplasm of the cells, but no cell nuclei are present here. Compare cells which contain cell nuclei and the cells which contain no cell nuclei. Around here we see some cell nuclei. They are cell nuclei of loose fibrous connective tissue and blood vessels. But we are talking about the death of nephrons. Nephrons cells are here and they contain no nuclei. It means that they are dead. Here we see the necrosis of skeletal muscles, the Zenker's necrosis, with petrification. Petrification means deposition of calcium salts in the area of necrosis. Here we see oblique sectioned skeletal muscle fibers. These pinkish structures are oblique sectioned muscle fibers, and some of them are surrounded with petrification areas, which are blue in color. We can say that these skeletal muscles are necrotic. They are dead because they contain no cell nuclei. Cell nuclei which we see here at the periphery are actually the cell nuclei of loose fibrous connective tissue. Another example of the same necrosis of skeletal muscles with petrification shows us some necrotic skeletal muscles. Number one here, and this one is also necrotic because here we see no cell nuclei. Only here, but this one changes its shape and it is dying cell nucleus. So most of this section of the muscle fiber contains no nuclei. It means that it is dead. And number two shows us the area of petrification, the deposition of calcium salts around the dead muscle fiber. They are blue in color. Here we see the leukophatic necrosis of the brain tissue. So all this area shows us the area of necrosis. Here the tissue is dead, and the cavity starts to be formed in this place of dead tissue. Here we see the different types of gangrena, the dry gangrene and the wet gangrene. Dry gangrene of tools. Um, Here the tissue is dry, shrunken, and dark in color because of formation of iron sulfide. Hydrogen sulfide, H2S, released from bacteria, reacts with iron from hemoglobin and form iron sulfide, ferrum S. So this substance gives this black color in this area. Here we see wet gangrene in the small intestine. This area, which has abnormally red and brown color, this is the area of the wet gangrene. Caseous necrosis. Here you see the anatomical preparation. This area shows the caseous necrosis, a cheesy, likeish structure, and the same on the histological preparation. The area of necrosis is here. It is equally pink in color, and no cell nuclei are present here because all the cells are dead. And it is surrounded with macrophages and other inflammatory cells. Um, and all this appearance is characteristic of a nodular inflammatory lesion called a granuloma. So this oval shaped structure is called granuloma with caseous necrosis. It contains the area containing dead cells, necrotic area, no cell nuclei are seen here, and the area of surrounding inflammatory cells and macrophages. So here we have macrophages, neutrophils, and other inflammatory cells. They try to eat the dead cells and to fight some bacteria which can cause this necrosis. So inflammatory cells and macrophage surround the damaged area from the normal tissue. They make a kind of wall that protects the normal tissue from the area of the necrosis. Here in this picture we have the infarction of the lung. So here is normal lung tissue, which is pink in color, and this brown in color. It's the red hemorrhagic infarction, which is characteristic for lungs. In lungs, we usually have red and not white infarction. This is why this area is more red looking than normal. Wedge shaped means triangular in shape, um, like this. This will be the top of this triangular in shaped area, and the basis is here. White infarction in kidney, the same picture showing how it happened. So artery which comes this way and then it is split into smaller ones, and anterior arterioles give blood supply to all this area. So something had blocked the passage of blood to this area and it caused the necrosis in this triangular shape. So this is what we see here. White necrosis area. Some uh, necrotic areas in spleen look almost the same, also usually triangular in shape. Here we see once again red pulmonary infarction. It is hemorrhagic. It means that this area is filled with red blood cells released from damaged blood vessels, which fill the necrotic tissue. This is why it looks more red and brown in color. Brown because of hemosiderin released from dead erythrocytes. So this area looks more red than normal tissue. And this area in histological preparation, number 1 shows us the more normal tissue, and number 2 shows us the infarct area. Because here we have the hemorrhagic infarction in lung, it means that this area is overfilled with blood cells, red blood cells. This is why this area looks more red in color. The dead cells, the dead alveoli cells and other cells which become dead here, they now are just the mass of dead cytoplasm, which is also eosinophilic. Here we see the thickened and sclerotic and interalveolar septa. It means that the spaces between the two adjacent alveoli, the walls, which are called septi, are thicker than normal because some connective tissue is overgrown here, which is called sclerosis. This is what means sclerotic interalveolar septa. Septa means the wall between two alveoli. Inter means between. Alveolar means between alveoli. In infarction area, alveolar walls, vascular walls, and bronchioles are necrotic. So all of the cells which make these structures are dead now. We cannot see their cell nuclei, only red in color mass of dead cytoplasm of these cells. They appear eosinophilic, homogeneous, lacking the nuclei, but keep their shapes, structured necrosis. And a lot of red blood cells, which give more red color. More pink color is for dead cells, more red color is for invading red blood cells during hemorrhage. The same on high magnification. Number 1 shows us the wall of the alveolus. So it is more darkly red in color. More whitish, more pale areas are the inner spaces of alveoli, which normally should contain nothing, but here they contain some dead cells, red blood cells, etc. So these alveoli cannot perform their function anymore. Necrotic alveolar walls means that the cells which make the walls of alveoli are also dead, so everything is dead here, and lung in this area cannot perform its function. Number 2 is for red blood cells in alveolar lumens. So you can see here also the cells which fill the lumens of alveoli, which normally should contain only air. And the final picture that was present in that presentation shows us connective tissue scar in myocardium after the infarction of myocardium. This is the transverse horizontal section of the heart. This is the cavity of the left ventricle. It's the cavity of the right ventricle, the septa between two ventricles, more red in color. This is normal myocardium, red because here we have cardiac muscle cells in myocardium. Here more yellow color is for adipose tissue in epicardium. It is normal tissue. Here everything is okay, but we should look to this area here. All this area is pale yellow in color. This is also the wall of left ventricle, but here it contains cardiac muscle cells, and here no cardiac muscle cells. They all are dead because of infarction, because of lack of oxygen. For some reasons, no blood came here for some reasons, and all cardiomyocytes are dead now. And the area of the dead cells is now overfilled with connective tissue. So this area is the connective tissue scar in myocardium. So it was the last picture. If you have any questions, please ask them now, or if you will have some questions about the pictures or about something else on pathology, you can send your questions in our WhatsApp chats. If you have no questions, then thank you for your attention. If this explanation was helpful, it will be a great pleasure for me.
Thank you very much, Professor.
Thank you, everybody, and have a nice day.